I am the principal of Moogambigai Dental College and Hospital, which is located in the state of Tamil Nadu, in the capital city of Chennai. I am very thankful to the organizers of this international conference on dentistry and oral health, the 8th edition. Thank you so much for inviting me for this virtual keynote presentation. My topic for today's keynote presentation is future of dental implant therapy from no teeth to teeth using the BCS implants. Now, what is the BCS implant? So I'm going to cover the following contents. So BCS implants are basically a category of corticobasal implants which are osseo-fixated in cortical bone, especially the first cortical and the second cortical, with the intention to use them for an immediate loading protocol. Now, under the corticobasal systems, we have the KOC, which is the abbreviation of King of Compression, KOC systems. And then we have the BCS system, which is bicortical screws. And then we have the BCS EX. EX stands for extraction socket. Now, these are the clinical procedures which are involved in carrying these implants from the unique instrument called grip holder or the hand grip instrument. So you open up the vial, the sterile vial, you carry the implant, break open, and then place it in the bone with manual torque. The one on this slide is currently the KOC implant, which is a combination of rough surface and smooth surface implant. Now you have the BCS system, the bicortical screws, and the EX. So these are basically smooth surface implants made from high-grade, medical-grade titanium alloy. These are inserted with a manual torque, piercing through the first cortical layer and then through the cancellous or trabecular bone, and then engaged by way of osseo-fixation into the second cortical or even sometimes a third cortical. When I say the second cortical, I mean the layer of cortical bone which is there deep inside beneath the trabecular bone pattern in the edentulous maxilla or edentulous mandible, or it could be a partially edentulous maxilla or a partially edentulous mandible. These implants are osseo-fixated and are said to have wonderful primary stability with your primary torque values exceeding 70 to 80 newtons, which is very thankful to the osseo-fixation principle, which is a principle derived from orthopedics, from the branch of orthopedics. Various orthopedic implants utilize the same principle for fixation of implants in bone, especially long bones of the lower limbs or upper limbs. These are basically dental implants with smooth surface throughout from the head abutment to the top of the implant. These are basically one-piece implants will eliminate peri-implantitis or varicositis events. In fact, I would definitely say with confidence that once these implants are inserted into bone, following the adequate principles which I will be covering shortly, there is no question of peri-implantitis or pericositis. Now I am going into the scientific methods which will cover general methods and site-specific methods for insertion of these smooth surface implants. Method 1A, subdivision A to H. So here these implants are supposed to be placed never in a unidirectional way but in a multidirectional way, because these single piece implants are always available with abutment head with a unique frictional feature, serrational feature, which will aid in cementation of final prosthesis, and multi-directional placement is always possible because of
Dr.
the
Hariharan.
bendable property of the abutment head up to 15 degrees. And we call it as engagement of the second bone as specific. Yes.
Could you please adjust your mic
settings? Can
settings?
you hear me?
Yes. Could you please adjust your mic settings? We get echo sound in mid.
These implants are placed in the second cortical region. What do you want me to do, please?
Now your audio is fine. We get an echo sound in the mid. No, it's fine. Please proceed, doctor.
Yeah, I'm continuing.
Okay.
Yeah. So I'm engaging the second and the third cortical bone. Okay. When I say the second cortical bone, I mean the layer of bone which is there beneath the cancellous or the bone areas, includes the canine fossa region, the buttress bone below the mylohyoid region of the mandible. Okay, these are few examples which I have given for third cortical bone. Then these smooth surface implants can also be placed in periodontally compromised mouths where we need to eliminate or extract the existing compromised dentition. You can irrigate with the available oral antibiotic solutions or any antimicrobial irrigants, and then you can straight away place the implants. Then coming to method 1C. So avoid placements in cancellous and spongy bone because these are specialized implants not to be placed following the principles of conventional implants. Then you gain greater mechanical anchorage when the tip of the implant is placed in the second or third cortical region. Then, as I said before a few minutes back, the shaft of these implants can be bent by up to 15 degrees, wherein multi-directional placement is definitely possible. Then possible with BCS as well as KOC implants. Now coming to the site-specific methods, the second method in the classification where the mental foramen region. Can you see the picture? So these BCS implants are placed in a multi-directional way in between the mental foramen. Now, all these methods which I am talking right now had already been published in the Annals of Maxillofacial Surgery, Journal, year 2020, page 457 to 62, which I have mentioned in the footnote. So, method 3 is placement between the implants, the BCS implant, between the root of the canine and the mental foramen. So you can see 4 different BCS implants have utilized the distal portion with its zirconia crowns. Then method 4A and 4B, where the implants are positioned bypassing the inferior alveolar nerve on the lingual side without penetrating the apex through the cortical bone available. And 4B is also endosseous positioning, bypassing the inferior alveolar nerve on the lingual side with penetration. The previous one was without penetration. Here, the tip of the implant will penetrate the cortical bone, as you can see in the picture. So this is another example where you can see the tip of the implants have penetrated. So a 3D printed mandibular picture is also shown, where I have shown how the piercing takes place in a multi-directional way, angular way. Then method 6 is placement of implants in the region of tuberosity of the maxilla, even in the presence of extraction sockets. Method 7, division A, where the implants are placed in the nasal, where the palatal side of a knife-edge maxilla directly engaging the nasal floor. 8A and B, where we use the cortical floor of the maxillary sinus of the maxilla, or we utilize intrasinusal septum for the placement of BCS implants. Method 9A and 9B, the BCS implant is anchored in the floor of the nose or in the median raphe of the maxilla. The former is 9A, the later is 9B. So in this picture, can you see how it is engaged, the BCS implant? Can you see the curvature of the shaft? So that is because of the bendable property of the implant. Then method 10A and 10B, where the cortical bone of the pterygoid plate of the sphenoid bone is utilized. These are called pterygoid implants. Sometimes we can place double implants also. If there is enough space, you can even go for a trio of implants also. Even 3 tuberopterygoid implants can be placed. Method 11A, engaging the palatal side of the maxillary sinus or engaging the median raphe of maxilla from the lateral aspect. Can you see the picture where the lateral aspect is being engaged in the radiographic picture on the left side of the slide? Then method 12A, this is really a unique method. I would definitely speak on it. It's called the zygomatic process of the maxilla, which is abundant with cortical bone. Therefore, the single piece long length BCS implants measuring from 40 millimeters to goes up to 60 millimeters. Okay, you can engage the body of the zygoma for osteofixation and enhanced primary stability. The system which I recommend I use routinely in my practice is the system called HIDE, the HIDE system. Back in my country, we call it as Simpladent. Amazing system. Then method 13 is placement of the implants into the basal bone. So what is basal bone? The basal bone is the residual bone, intact bone, left after extensive resorption of the maxilla and mandible following extraction. So this picture shows you the amount of bone reduction that has taken place due to the atrophy of the lower jaw. Then method 14 is placement of the implants in the fresh extraction sockets of the first and the second premolar region, either maxilla or mandible. Method 15 is placement of implants, BCS implants, in the fresh extraction sockets of maxillary first and second molar regions. So usually in the molar regions, the socket is usually bigger in nature compared to the maxillary premolars. Therefore, we utilize, we recommend, we advise placing two different BCS implants into the palatal socket, one, and into the mesiobuccal socket, the second one, in a multi-directional way. Method 16A and 16B, two implants shall be placed into the extraction socket of maxillary first premolar. So this is a unique method where even in a maxillary first premolar socket, which is usually comparatively smaller compared to a molar, but still we use two implants taking into account the existing circumference of the extraction socket of the first premolar. Method 16B, two or three implants shall be placed into the upper first or second molar. And remember, this is an alternative to method 10. So can you see the picture where in the first premolar region, okay, we have come across placement of two implants parallel to each other, and these are bendable implants. So now I'm coming to the third part of my presentation. Initial part was my introduction and classification. The second part was the general methods and the site-specific methods of placement of corticobasal, especially BCS implants, which I described just now method-wise, starting from general methods 1A to 1H, and then followed by site-specific methods, where I described up to 16 different methods. Now let me go to the realistic part, the clinical part. I'm just going to discuss few of my recently completed clinical cases. Now this is one 38-year-old male patient who came with a history of missing Q1, okay? And the time, look at his poor oral hygiene, okay? So we subjected him to the scaling process initially. So soft tissue overhangs were there. So we strongly recommended cortical implants for this patient because of the available short duration, because he was in a hurry to have the teeth replaced. So on the OPG, you could see the available bone length was around 15 mm from the crest of the socket until the floor of the nose or the sinus floor. Okay. And then we place a 26 mm implant, a 26 mm BCS implant engaging the second cortical, as you see in the upper left clinical picture. Okay. And in the next picture, you can see a monolithic zirconia crown being cemented the very next day of placement. So the X-ray shows the 26 mm length of BCS implant engaging the nasal floor. Okay. So osseo-fixated, followed by immediate loading protocol with the monolithic zirconia crown. And can you see the two bilateral wings that is well seen along with the monolithic zirconia crown? Those are small tiny wings, lateral wings, which are incorporated into the crown during the fabrication process in the laboratory to enhance added retention apart from the adhesive cement which we will be using for the cementation process, and also to prevent a rotation of the crown around the implant. So this is one unique feature which we usually provide during the fabrication process of the crowns in the laboratory, and it is also noted down in the laboratory form. So that's the final processes. Okay, so in the final processes, I had also compensated for the loss of soft tissue by providing a small amount of gingival ceramic. The next second case history is about a 53-year-old completely dentulous male. Okay, he is already wearing a complete denture, which is 7 years old. And he was so tired of the looseness of the complete dentures because of resorption process. He opted for a fixed process, but at the same time, he was looking to get things done in a short period of time. So I had advised him corticobasal implants, that's a pre-op OPG. So can you see how resolved the maxilla is? In the posterior part, hardly any vertical height of the bone. And can you see how the picture is, clinical picture gives you a picture as though the vertical height is good, but in reality that is the greater amount of connective tissue which is giving a false appearance of greater vertical ridge height. So as a thumb and completely edentulous jaws, we prefer giving BCS implants 10 to 12 in the maxilla, 8 to 10 in the mandible. Then we place impression copings around orange plus 1 and we make a pickup impression with addition silicone alone. We do not use light body because of the possibility of light body material passing through the gingival crevice and disturbing the placement of. Then in the subsequent visit, we perform a jig trial. The vertical height of these implants, one piece implants, will be reduced according to the provided jig from the laboratory. Then we make a trial of the framework of the bar, the uniting bar of these implants, then followed by a tentative centric relation record, a jaw relation, and in the subsequent visit, we do a trial denture verification of the jaw relation. These are, kindly remember, these are Ivoclar teeth specially designed and manufactured for corticobasal implants, high strength, high compressive and high tensile strength, Ivoclar teeth. And then the final hybrid prosthesis is ready for cementation. These prostheses are cementable prostheses. So I have on the master casts, the intaglio surface. So over these available holes, I have utilized an adhesive cement. The usual adhesive cement is a water resistant or hydrophilic glass ionomer cement. So these are the frontal right lateral and left lateral views of the final hybrid cemented prostheses. Now, coming to the next case report, also done by me. This is a female patient where she has reported she was almost in tears because she was emotionally upset that she couldn't have a good set of dentition. So this is how our pre-op OPG was at the time of first visit. So I recommended corticobasal implants. She was a government employee and she hardly had any leaves available. She had exhausted. So I recommended her corticobasal implants and she immediately obliged. So again, we placed pterygoid implants, one each on the right and left side of the maxilla, then followed by placement of strategic implants in strategic regions of the maxilla and mandible. So as I said before in my case report 2, the thumb rule is 8 to 10 in the mandible, 10 to 12 in the maxillary region. So these are smooth surface implants with thread pattern appearing only in the apical third, which will engage the second corticals. So the post-surgical view of implants. Now, can you see these implants are now multidirectional in nature? Then impression copings. Impressions made again with A silicone, no light body. So this is something which I would like to say. So this is basically a putty impression, which is given as a cover method, given as a template to protect the implants, because these implants, if left as such after impression, so they tend to come close to each other and disturb the patient at the time of chewing and mastication. So therefore, I always prefer giving a addition silicone template just as a protective cover for the maxillary implants alone. So these are the splinting bars which will be placed over the implants. So can you see how the splinting is being brought into effect? all these implants, maxilla and mandibular implants, are splintered together with the help of the bar. So trial dentures on master casts, trial dentures in the patient's mouth, and then once again the final hybrid prosthesis on the master casts. High strength, durable, Ivoclar hybrid prosthesis, the intaglio surface, intraoral view, frontal, right lateral and left lateral views in occlusion. So we provide something called as implant protective occlusion. So wherein all high points in all possible movements of the mandible is checked and rechecked again with special articulating papers. And then we remove these, check again, and then finally provide an implant protective occlusion. So this is the post-cementation view of the same patient, the third patient. Post-cementation OPG of the hybrid prosthesis. So I would like to conclude my presentation today by making one clear statement that corticobasal implantology is a different ball game and not to be compared with conventional implantology. This is purely science-based, and there are lots of scientific evidence with long-term studies also available online. Okay. And these implants are immediate functional loading implants. So teeth to no teeth in a period of 3 days is a real big achievement for any prosthodontist or implantologist. And I strongly recommend the corticobasal implants. They are the futures, and it is already being extensively used in Russia and many countries of European continent. Okay, back in my country. So this system had gained great, immense significance based on its scientific data and potential. And I strongly recommend this system among all our peers. Thank you once again, the organizing team of International Conference of the Dentistry and Oral Health from Spain. Thank you to the Magnus organizers of this conference. And thank you once again. I am welcome to any questions at this point of time, please.
Thank you, Dr. Hariharan Ramakrishnan, for addressing such an interesting topic. I would like to request the audience, if you have any questions, kindly unmute and ask directly.
Yes. So you can always contact me through my email also, which is available on my university website, Dr. MGR Educational and Research Institute. Okay. So feel free to visit my university website anytime. Feel free to contact me via my institutional email, which is available on the website. Most welcome. I will be answering you as soon as possible. It won't take, I promise I will not delay in responding back to your queries if raised over my institutional email ID.